Well, thank you everybody for coming to this lecture. So I'm Kitamura. I work with the Department of Radiology. My predominant specialty is musculoskeletal radiology. And, with COVID and whatnot, our MSK ultrasound service was predominantly shut down, but we're restarting it recently. So we wanted to give everybody an update of what kind of things that, what kind of services and exams we can offer. So I know this is a specialty based in ultrasound, but I do have some slides. I'm sure everybody is aware that we use an ultrasound probe that acts as a sender receiver, sending ultrasound waves to the structure of interest. And in this case, it'll be things like joints, muscles, and bones. And when the sound reflects back, we create images based on sound attenuation. We describe these in terms of relative echogenicity. Specific to MSK ultrasound, we generally refer to structures as isoechoic when the signal or the echo texture is similar to the underlying muscle. If it's brighter than that, we could describe it as hyperechoic. Things like bones would fit under that category. If you really can't see anything behind it because of a hyperdense foreign body, i.e. things like surgical clips or even things like retained hardware, you won't really be able to see anything behind it and be described as reflective. On the other side of the spectrum, if it's darker than the underlying muscle, you could describe it as either hypoechoic or anechoic if you really can't see any signal within that structure. So these are some representative structures that may look like those echo textures under ultrasound. So with MSK ultrasound, we typically focus on the hypoechoic to hyperechoic kind of spectrum. And again, if you see something hyperdense or maybe like surgical clips or whatnot, that could be described as reflective. On the other hand, if you see a cystic structure in the body, that could be described as anechoic. And of course, one of the big advantages of using ultrasound is that we can use Doppler to visualize flow based on the change in frequency, based on whether the object is moving towards you or away from you. So what are some of the advantages of MSK ultrasound? Why even bother? Well, one of the big advantages is that, of course, it doesn't have any magnetic field like an MRI. Every once in a while, we hear about like a catastrophic accident where something is taken in that's metallic into the MRI, causing injury to the patient. And some patients are just really claustrophobic and they can't really handle an MRI. So if you have like a patient who kind of fits those categories, MSK ultrasound may be a good consideration. Of course, patients who have pacemakers and coils who where those may not be MRI compatible would also be another good candidate for MSK ultrasound. Another good advantage of MSK ultrasound is, of course, that it's a dynamic examination. So if you have a patient who's complaining of specific symptoms that are maybe only manifested with particular maneuvers, particular positions, MSK ultrasound would be a good consideration because all you need to do is put the probe on the patient and have them reproduce that maneuver that's eliciting the patient's pain and discomfort. Things like snapping hip, subcoracoid, subdeltoid impingements are often a dynamic pathology. And things like biceps tendon subluxation or ulnar nerve subluxation are good candidates for ultrasound examination. They can be a shorter examination where we can provide immediate feedback. So as an example, a typical extremity MRI typically takes about 45 minutes. And a complete shoulder ultrasound, the amount of time it takes is about commensurate or equal to a typical MRI. So we're not really saving a lot of time there. But say if a patient has a focal extremity complaint like medial elbow pain or posterior ankle pain, and you're wondering about like an Achilles tendon tear, well, then you could just put the probe on the patient, and that exam could be as short as 5 minutes, right? You put the probe on the patient, you make the diagnosis, you move on. And it's considered to be more cost effective. I mean, I won't get into all the CPT codes and whatnot, but it's considered to be more cost effective. One of the other advantages is that we could typically do a combo exam where we could take a look at the patient's underlying structures, maybe diagnose a tear. And if there isn't a tear, we could do an injection. So we could say, yes, no, there is a tear. And if there is no tear, then we can also inject, say, something like a bursa or a joint so that, you could provide the patient some relief and also try to kind of narrow down the patient's diagnosis, almost kind of like a 2-for-1 deal at the same time. And I'll have an example case of this a little bit later. So it's not kind of like a end-all examination, right? It's not a perfect modality. There are going to be some disadvantages. One of the disadvantages is that there are certain structures that are really not well evaluated with ultrasound, things like bones and deeper intra-articular structures like the labrum, the cartilage. There are some people saying you could look at the ACL and PCL. I'm not really sold on it. And I don't really think you could get like a good evaluation of things like cruciate ligaments on ultrasound. And you can see on the right-hand side image, this is the posterior shoulder, and I could label certain structures because we know what it's supposed to look like. And if I outline them, this is kind of like what it's supposed to look like. But it's really hard to get like a good view of the deeper portions of the glenoid and the humeral head. And you're only getting a small portion of the labrum kind of visualized. So you can see how that could be a limiting factor. The other big disadvantage is the human element. So unfortunately, as we trend from the left-hand side of the screen to the right-hand side of the screen, which just seems like that's what's happening to the population currently, it becomes more and more difficult to evaluate structures under ultrasound because you have to penetrate so much of the subcutaneous soft tissue to access or to visualize the underlying structures. And the other thing is patient cooperation. So when we're doing ultrasound, I mean, you're basically like face-to-face with the patient. You really need them to be able to cooperate with you because you're moving their joints and their muscles in particular positions, particularly with dynamic exams. So you really need for them to be able to follow your instructions, kind of work with you. And you can see how this became a problem in the COVID era because, you know, it was very difficult to be face-to-face with the patients. And if you have, say, like a demented patient or a very belligerent patient, MSK ultrasound may not be the best modality to examine the patient in those cases. So some of the potential pitfalls of MSK ultrasound. So it is operator dependent. I'm sure you guys are all aware that there are people who are very good at it and people who need a little bit more practice. So it's just something that you have to be aware of all the potential pitfalls and be comfortable with the modality or be comfortable with who's doing it for you. So this is a good example image of an MSK ultrasound. So this is a short axis view of the long hip biceps tendon. If I were to draw out the structures, the green dotted lines denotes the subcutaneous soft tissue layer. The yellow denotes the deltoid muscle. The white denotes the bone cortex, specifically the proximal humerus. And you could see how the long hip biceps tendon is seated within the bicipital groove. So what are some of the things that could go wrong when you're doing these examinations? Well, the big thing is anisotropy. So that means that your probe or your ultrasound beam is not perfectly perpendicular to the underlying structures. And you could see how on the left-hand side, your biceps tendon looks artificially hypoechoic or dark. Well, in MSK ultrasound, how we diagnose pathology is we're looking for fluid or for hypoechoic signal where there's not supposed to be any. So if this was a real finding, then we would be able to diagnose things like either a biceps tendon tear or biceps tendinopathy. But this was actually not the case. This is just anisotropy where the probe is no longer perpendicular to the structure. So if you're not using the correct technique, you could basically create pathology where there really isn't any. Is there any way to this? I just can't see what I just want to move this so I could like,
I think you hit that one.
There, that's better. Okay. So yeah, I just couldn't see what I was supposed to be presenting. Okay. So this is where the depth is too high. You can see how, you know, we're going to like maybe 4.5 centimeters and there's just a lot of structure on the screen that's not really providing you any information. So you really want to try to optimize your images so that the structure of interest is filling your screen or is centered in your screen. So this is a case of wrong focal zone. You can see how the focal zone denoted by that hourglass is really not centered in the area of structure, which I would ideally like right smack in the middle of the long hip biceps tendon. So this is a case of too low frequency. So with very superficial structures, I like to go 15, maybe even 24 megahertz. But with bigger patients, with deeper structures, you may have to lower your frequency to as low as 9 megahertz. And I don't think there's really any like, you know, hard and fast rule to decide what frequency you should use. It kind of comes with experience and basically just trying to make your images look, for the lack of a better word, pretty. So this is a case of no compounding. I think it's important to be aware of the machine you're using. So there are things like compounding, harmonics, certain techniques you can use with a particular vendor to make your images look better. The modern GE machines don't even have focal zones anymore. So, you know, some of these knobology topics might be a little bit irrelevant, but I think it just bears that you just have to be aware of what kind of optimizing techniques you have on your particular machine. Just make sure your total gain compensation is aligned. So I usually like it kind of like straight down the line, but sometimes it just doesn't work and you'll get like a dark band and you do have to compensate for it. So if your images look kind of funny, you know, it might be one of the parameters you might have to mess with. When you're looking at Doppler signal to see if there's flow going in a tubular structure and whether you're wondering if it's like a ganglion cyst or a mass or a vessel, you know, we always go to our color Doppler or our power Doppler. Just make sure your gate is not too high and you're not artificially creating an area of avascular focus. And on the other hand, if your gate is too low, you know, you're just going to get too much flash artifact and you won't really even know if that signal is abnormal or not. So just be aware of what your optimal gate settings are going to be. So these are kind of like the summary slides of, you know, some of the advantages and disadvantages of MSK ultrasound. I won't repeat myself, but, you know, it basically just summarizes everything that we just kind of talked about. And these are some of the good indications for MSK ultrasound. Again, just kind of like summarizing everything that we've discussed up to this point. If you want to go back and kind of like rewatch this lecture, you can just kind of like, you know, screenshot this slide if you want to just have like a good reference sometime in the future. All right, so now getting into kind of like the meat of the topic, some select MSK ultrasound. So this is a normal supraspinatus tendon. On the left-hand side of the screen, I have a coronal T2 weighted sequence MRI image. You can see how the supraspinatus tendon, denoted by that blue arrow, inserts into the greater tuberosity of the humerus or the proximal humerus. And on the right-hand side, you will see a correlatory MSK ultrasound image with, again, the blue arrow pointing to the normal supraspinatus tendon. If I were to outline the two relevant structures, this is what it will look like. You could see the blue dotted lines outlining the normal supraspinatus tendon and the green dotted lines outlining the humerus. And you could see this is how a normal tendon and ligament looks under ultrasound. And this is true for most parts of the body. Normal tendons and ligaments always look like this. They always have this hyperechoic, fibrillar, kind of pactin appearance. It looks almost like dry angel hair pasta. It's kind of like how I think about it. So is what we're showing you, or is the images that we're showing you actually, you know, does it correlate with MRI? Well, it does. So this is a short axis MRI image of the supraspinatus on the left-hand side of the image and the correlatory MSK ultrasound on the right-hand side of the image. So on the left-hand side, you can see the yellow arrow pointing to the long head biceps tendon in short axis within the rotator interval, and the blue arrow pointing to the short axis image of the supraspinatus tendon. And you could see how the ultrasound image on the right-hand side looks exactly like it, with the yellow arrow pointing to the short head of the long head of the biceps tendon in the rotator interval, and the blue arrow pointing to the short axis view of the supraspinatus tendon. Here's a long axis view of a subscapularis. You could see an axial MRI on the left-hand side. And the way we kind of show the subscapularis tendon on the ultrasound is we typically look for the coracoid process, which is denoted by that yellow arrow. So you can see how on the right-hand side of the image, the yellow arrow points to that curvilinear hyperechoic structure that denotes the coracoid process. And the blue arrow in this case points to the long axis view of the subscapularis tendon. And again, just like the normal supraspinatus tendon, you can see how a normal subscapularis tendon has a very similar appearance. It has that thin, hyperechoic, fibrillar, again, like angel hair pasta appearance. So that's, again, a normal appearing tendon, and normal appearing ligaments also appear very similar. Not to harp too much on this, but, you know, again, some correlation images between MRIs and MSK ultrasound. So the yellow arrow points to the short axis view of the long head biceps tendon in the rotator interval. And this is a short axis view of the subscapularis tendon. You could see how on the right-hand side of the image, you could see like, you know, maybe 4 to 5 arms of the subscapularis denoted by those round hyperechoic foci. And that's a again, a normal image of a subscapularis tendon. Here's a posterior view of the glenohumeral joint. You could see how on the left-hand side, you see the MRI. We would put the probe on the posterior side of the glenohumeral joint. And on the right-hand side of the image, you could see a correlatory MSK ultrasound image. You could see the glenoid, the humeral head, and the labrum, especially if I kind of like outline it, and you can see how it correlates with the MRI image on the left-hand side. All right, so now we could talk a little bit about pathology itself. So this was a 86-year-old female. She came in with worsening shoulder pain, and for some reason she couldn't get an MRI. Maybe she had some non-MR compatible embolization coils or like a pacemaker, or maybe she was just frankly claustrophobic. So then the probe would be placed kind of along the long axis of the supraspinatus tendon, like so. So that's our scanning plane. So I have a normal ultrasound image on the left-hand side of the screen and the patient's ultrasound image on the right-hand side of the screen. And you can see how there's a distinct difference between the two images. On the right-hand side of the image, you're seeing this anechoic focus between the footprint of the greater tuberosity and the supraspinatus tendon. And this patient had a case of full thickness supraspinatus tendon tear. And when you have a tear in the body, you create a potential space that's going to be filled up with fluid. And that's basically what we're looking for in this case. We're looking for that anechoic fluid that's filling up that potential space created by that supraspinatus tendon tear. This patient also got an MRI, so she must have just been claustrophobic. And you can see how the images correlate. You can see that full thickness tear both on the MSK ultrasound and on the MRI. And we can scan a little bit lower on the patient's shoulder, and you could see how she also has a large subacromial subdeltoid bursitis that's often associated with these full thickness tears of the cuff. That blue arrow on the left-hand side of the image denotes the subscapular, the subacromial subdeltoid recess. And that's generally denoted by that thin hyperechoic line on a normal, young, healthy patient. It's usually not filled with fluid, even though it is a physiologic bursa. But once it becomes pathologic, it can be filled up with fluid, like in the patient on the right-hand side of the image. And those hyperechoic foci within that subacromial subdeltoid bursa are areas of synovitis. Unfortunately, this patient, again, had that same MRI, and you could see how the images correlate really well. You could see that subacromial subdeltoid bursitis on the left-hand side of the image, which basically looks identical to the ultrasound images on the right-hand side of the image. So this is all to say we're not just making these things up, right? So the pathology is real and you can't see it on the ultrasound. So if you make these findings under ultrasound, are they eventually gonna need an MRI anyway? Why even bother? Well, can we make all the findings that are necessary to decide whether the orthopedist is gonna take the patient to surgery or not? Well, we definitely can make all those findings. So we could look at, so the things that the orthopedics wants to know are things like the degree of retraction, which is denoted by that yellow line. So we would measure that out on these long axis images of the rotator cuff, and we will tell them, okay, the patient's tendon is retracted by this much. They also want to know what's the thickness of the tear. Is it a full thickness tear or is it a partial thickness tear? If it's a partial thickness tear, is it articular-sided or bursal-sided? And in our case, you could see a little bit of thin hyperechoic fiber, kind of, little remnant fiber between the retracted tendon and the greater tuberosity. But I would probably call this full thickness because I think that fiber is pretty much like insufficient to hold that cuff tendon in place anyways. They also want to know the degree of underlying tendinosis, which generally we look at the degree of hypoechogenicity within the underlying tendon. And you could see on this patient, the patient's underlying tendon still looks hyperechoic and fibrillar. So that's a normal appearing tendon that just has like a full thickness tear. But if that retracted tendon looked darker, looked thicker, I would probably call some amount of tendinosis. We can also tell them where the tendon is located, and the landmark that I use is the long hip biceps tendon within the rotator interval. So the supraspinatus tendon inserts just posterior to that long hip biceps tendon, and you could see based on this image that the cuff tear or the supraspinatus tendon tear is probably anterior to mid in extent, denoted by that yellow line. So I would say anterior to mid supraspinatus tendon footprint tear, full thickness with however much retraction we measured previously. We can also look at the degree of muscle atrophy because that's kind of like the last key of the puzzle that they want to know. You can see on the left-hand side of the image, a normal muscle appears hypoechoic, fills the supraspinatus fossa, while abnormal cases, the muscles tend to appear more hyperechoic, they tend to appear more fibrillar, and the volume is decreased.
Hey, Gene, on this slide right here, where are we scanning it?
So this one is the supraspinatus fossa. So what I do is I feel for the patient's spine and I put the probe just above it. So this is the supraspinatus muscle kind of filling up the supraspinatus fossa.
So kind of like posterior.
Correct. Yes, I approach it posteriorly. I feel for the patient's spine and just put the probe just above it. And you can see how, it does correlate. So you can see how on the bottom side of the image, a normal supraspinatus muscle kind of fills up that supraspinatus fossa, while as it atrophies away, it goes from the left-hand side of the image to the right-hand side of the image, where it becomes decreased in volume and more infiltrated with fat. And that's something that you can actually see under ultrasound, as you can see on the upper right-hand side of the image. So here's another image of the shoulder. So now we're just gonna scan perpendicular to the long humeral shaft. And you can see an MRI on the right-hand side of the image, just kind of showing the scanning plane. So I'm just gonna look at the long hip biceps tendon here. This is the extra-articular or outside the joint long hip biceps tendon sitting in the groove. And you can see how it has a typical normal appearance of a long hip biceps tendon. It's thin, hyperechoic, fibrillar, again, like angel hair pasta. This was a 55-year-old patient with chronic shoulder pain. You can see the patient's ultrasound images on the right-hand side. And if you compare it to the normal left-hand side of the image, you can see two discrete findings. And that's that you have a little bit of tenosynovitis, i.e. fluid surrounding that tendon sheath. And you can see how the underlying long hip biceps tendon itself looks a lot more hypoechoic and disorganized compared to a normal image. And that's how we diagnose things like tendinosis or more generically, tendinopathy. When you have patients like this, you do have tenosynovitis, but oftentimes there's a lot of synovitis component around it. So it's pretty difficult to drain. But if the patients are having symptomatic issues, you can certainly inject these patients with anesthetic and steroids, and that's kind of like the general needle path that you would use. All right, great. This was another case, different patient. So this was a 45-year-old secretary. She came in with an acute on chronic shoulder pain. So she generally had some shoulder pain at baseline, but she had kind of like this acute exacerbation over the course of a couple of weeks. And you can see, there's really no need for ultrasound in this case if you're just trying to make a diagnosis. Well, that's calcific tendinopathy. I think everybody could see that. So where does ultrasound come into play in this case? Well, if you, for some reason, don't have an X-ray, you could certainly make the diagnosis of calcific tendinopathy just using ultrasound. You could see how on the right-hand side of the image, you could see that hyperechoic interface of the calcification. There's some posterior acoustic shadowing because of the density of that calcium, and you could make that diagnosis. But with ultrasound, you could even go a step further and even consider treating this patient. In those cases, you just basically take, I take an 18 gauge in these cases. You basically park it within that calcification and you could lavage it out or barbitage it out. You're not really, you're just trying to basically, I consider it like fracking. So you just kind of you just fill a syringe up with lidocaine and saline and you just try to force fluid into that structure. You're not gonna get much in, but as the plunger retracts, it kind of takes a little bit of that calcification out of that focus. And you just keep repeating that over a course of multiple syringes. And at the end of your procedure, you can see how now the calcification has decreased, and in that potential space of that focus of calcification, now you see some fluid. And this is what your syringe could look like at the end of your procedure. You could see some dense calcification that kind of precipitates in your syringe. And that's something that you can offer your patients if they're really bothered by their focus of calcification. And these are some of the, kind of like the summary indications of shoulders that you could do under ultrasound. You could look at, of course, the cuff tears and look at the biceps tendon pathology. And you could consider using it to treat things like calcific tendinopathy. You could certainly inject bursas and cases of tenosynovitis using ultrasound to guide your needle positioning. Now we could move down the arm. So this is a medial elbow, just kind of like a representative image that I took from the internet. You could see how you have some common flexor tendon attachments kind of along the medial humeral epicondylar region. And if you were to peel those muscles back, you would have the medial or the ulnar collateral ligament structures. And my yellow arrow in this case is pointing specifically to the anterior band of the ulnar collateral ligament. So if we were to put this, our probe on the patient, you could see how on ultrasound, it would look, that's how it would look under ultrasound. You could see how the blue arrow points to the common flexor tendon origin attaching to the medial humeral epicondylar region. And then deep to that structure is your anterior band of the ulnar collateral ligament. And you could see how there is some correlation between the images and the ultrasound. And just like the shoulder, a normal tendon, normal ligament always has a very similar appearance. Again, thin, hyperechoic, and fibrillar. And you can see how that kind of holds true in this normal elbow ultrasound. So this was a 49-year-old patient. This patient was a golfer. He came in with some medial elbow pain. You could see how if you compare the normal ultrasound images on the left-hand side of the screen to the right-hand side of the images, you could see how there's a distinct difference between the two images. On the right-hand side of the images, the common flexor tendon origins are now more hypoechoic or darker, and you can see how much more thickened it is compared to the left-hand side of the image. And that's how you can diagnose something like medial epicondylitis or tendinopathy of the common flexor tendon origin. If I were to put like a graphical representation of what's happening, it would look like the left-hand side of the image. So you have some tendinopathy, some low-grade tearing, some inflammation, and that's kind of like, you know, what you're seeing on the ultrasound. It's kind of like that inflammation, the edema that's manifesting secondary to the tendinopathy that you're kind of seeing under ultrasound. If you want to treat this patient, you could do a peritendinous anesthetic and steroid injection. Just make sure that you're not injecting into the tendon. You just want to inject around the tendon sheath. So I would just put it like just superficial to that thickened tendon if we were to consider injecting this patient for pain relief.
What's your anesthetic of choice and steroid of choice?
I used to use depomedrol, but here we really only have access to betamethasone. So we use like, 1 to 2 cc's of betamethasone and like, 1 to 2 cc's of lidocaine. But I think anything would work well.
So fairly small volume.
Yeah.
Very kind of.
Yeah, very, very small volume, like 1 cc's or like 40 of depo or something like that. We could look at things like the biceps tendon. So you could see how the, like the blue white arrows kind of denote the normal long hip biceps tendon attaching to the radial tuberosity. You could diagnose things like if your patient's concerned about biceps tendon tear, and if that's all they're worried about, I mean, they could certainly get an MRI, but if you really wanted to just diagnose the patient on the spot, you could do something like an ultrasound. You could see how, comparing the two images, you could see how there's a distinct difference between the left-hand side and the right-hand side of the image. You could see how like the normal, you could see how there's now fluid where you would expect the long hip biceps tendon to be. The degree of retraction can be denoted by that red line. You could talk about where the tear is. Is it at the insertion or is it more of a partial tear at the level of the myotendinous junction? You could use descriptive terms like, is it a partial tear? And if it's a partial tear, does it involve the short head or the long head? Of course, if it's a complete tear, that's what our images will look like, where the tendon would just be completely ripped off, say something like the radial tuberosity, and you could measure the degree of retraction. And in these cases also, you could kind of look at the retracted tendon and kind of give an idea of the degree of underlying tendinosis. You could see, if you kind of focus in on that blue arrow, that underlying tendon looks a little bit hypoechoic, looks a little bit more irregular. So we could probably give this patient something like mild to moderate underlying tendinosis. This is just a single image just showing that in some cases, you're like, not really worried particularly about the patient's tendon or the underlying bones, but they really have like this focal neuropathic symptom. And you can see how when you compare the two images, the normal case on the left-hand side and the abnormal case on the right-hand side, you can see on the left-hand side, the radial nerve typically It looks sometimes very similar to tendon. You're going to see some nerve sheath surrounded by the epineurium, and you can kind of see that image on the left-hand side. You can see some small nerve fascicles that's surrounded by that hyperechoic epineurium. And you can see how on the right-hand side of the image, that nerve has become more hypoechoic, more thickened, and you can see how the epineurium also looks a little bit irregular. It looks more hypoechoic and more irregular. So that's how you could diagnose things like focal neuropathy. And in this case, you could see that adjacent kind of curvilinear hypoechoic line adjacent to that radial nerve. So you could kind of tell that this is right at the level of the mid-humeral shaft. So this is like a case of things, something like Saturday night palsy. So if you have like patients who you're concerned about focal neuropathy, ultrasound could certainly help you kind of narrow your diagnosis if you know where you're looking for. So this is kind of like a summary slide of the things you could look under elbow ultrasounds. You could, of course, look at things like medial and lateral epicondylitis. We looked at the medial elbow or the golfer's elbow in our example images, but you could certainly look at the lateral collateral ligaments or the lateral epicondylitis. You could look at things like triceps tendinopathy. If you're wondering if your patient has, say, something like ulnar nerve subluxation, those are often dynamic cases where the ulnar nerve reduces with extension, but may sublux anteriorly to the medial humeral epicondyle with flexion. If that's what you're wondering about, just put the probe on the patient, have them reproduce the maneuvers and see if that ulnar nerve maybe subluxes into the anterior elbow region. And
pretty painful for the patient.
Yeah, it can be, but it's something that's pretty difficult to diagnose with MRI because the patients are usually in full extension, so we just can't see the subluxation with MRIs. So ultrasound could certainly be like a good modality to use in these patients. So moving down the arm, we could look at things like the wrist. So we're just going to focus. So we know that there are 6 wrist extensor compartments, and I'm just going to focus on one today. So we'll put the patient's thumb up and put the probe on the patient's thumb region. And in the first extensor compartment, we have 2 tendons, the abductor pollicis longus and the extensor pollicis brevis. And you can see those 2 tendons as discrete structures on top of the bone, denoted by that thin hyperechoic line. And if we were to put the probe on our particular patient, who was a 33-year-old nursing female who had wrist pain, again, you could see a distinct difference between the 2 images, the normal on the left-hand side and the abnormal on the right-hand side. Specifically, you could see some amount of fluid surrounding that tendon sheath, surrounding that tendon, and you could see how there's some thickening and some increased hypoechoic signal involving the one of the tendons, denoted by that blue arrow. So this is a case of De Quervain's tenosynovitis. And if you were to use color Doppler, which I always do in cases of tenosynovitis or synovitis, because it kind of gives you an idea of how much fluid there is versus how much synovitis there is. So we typically use color Doppler, not color Doppler, power Doppler, because we don't really care about the directionality of flow, but it is more sensitive in detecting some low-grade flow. So we used power Doppler in this case, and you can see how there's some increased signal in that what we consider tenosynovitis. And just like cases of the biceps tenosynovitis, if the patients are suffering from pain and discomfort, you could use your ultrasound to guide your needle injection. Fair warning, these patients really, really hate it when you stick that needle into that tenosynovitis because they're exquisitely tender and inflamed. So I usually give my patients fair warning, and when they invariably jump, just make sure you don't stab yourself, because as you can see, this is a very superficial injection. So if the patient's abruptly move, your needle could just pop out of the patient, and if you're applying force in a direction, you could end up stabbing yourself. So I would just be careful when you're injecting the patient's first extensor compartment.
You ever tried doing a peripheral block, distal to it and then going?
I never do. I guess it is a consideration, but yeah, I'm not super familiar with that technique. So yeah, I usually just go for it. But it's a consideration. So this was a 55-year-old female with trigger finger. So really nothing on ultrasound, maybe a little bit of arthritis, no acute fracture, maybe a little demineralized. So you could put the probe on the patient at the area of interest. And Honestly, when you're looking at pulley thickenings, if it's normal, I usually can't see it. And you can see on the left-hand side of the image, this is at the level of the A1 pulley. And if I were to squint and know what I'm looking for, can I hallucinate that I'm seeing a normal A1 pulley denoted by that yellow arrow? Yeah, maybe. But in this case, you can see on the right-hand side of the image, that pulley is a lot thicker and a lot more hypoechoic. So if you could discreetly say and point to a thickened pulley, it's probably abnormal. And that's what was going on with this patient. So she had a thickened A1 pulley resulting in a trigger finger. And you can see those images by comparing the left-hand side of the image and the right-hand side of the image. And I usually do contralateral examinations in these patients. So if the patient's having left hand pain, I look at the right hand to compare so that, you can increase your confidence that way, because if it's thickened on one side and normal on the other side, then, well, I think your confidence goes a lot higher than if it looked symmetric on both sides. We could certainly do things like synovial screens. I know rheumatology does this all the time. You could put the probe on the patient. If you're wondering about things like rheumatoid or gout, you could look for things like erosions. That's denoted by scalloping of the underlying bone. That could be denoted by that yellow arrow. And you could certainly put on your color Doppler or your power Doppler and see if there's any significant amount of synovitis. When you're doing these examinations, you want to put a little bit of pressure on your probe to displace any fluid so that you could just kind of get like a good idea of how much synovitis there is rather than how much joint effusion there is in these patients. And the thickness of the synovitis is something that you could follow over the course of time with treatment to see if that synovitis or that synovial thickening decreases over the course of treatment and time. We don't do this frequently, but we can. So if somebody is wondering about carpal tunnel syndrome, often it's a clinical diagnosis. I don't think there's really a whole lot of confusion if a patient has carpal tunnel. But if for some reason they want some confirmation, what you can do is you could look at the median nerve at the level of the pronator quadratus and also at the level of the carpal tunnel and compare their circumference. Their area. And if the area is different by greater than 2 square millimeters, you could have, it has been shown that there's a pretty high sensitivity and specificity that patient may have carpal tunnel syndrome. So you can see how on the left-hand side of the image, at the level of the pronator quadratus, we have an area of 5 square millimeters. And on the right-hand side, you can see at the carpal tunnel, it's 9 square millimeters. And that's a difference of 4 square millimeters. So we could confidently say that this patient has imaging findings consistent with carpal tunnel syndrome. And she did in fact, so we just kind of confirmed their suspicion. So other things, this is kind of like a summary of what we can do in the wrist and the hands. We could look at tendon and ligament injuries. We could look at pulleys. We can also look at extensor hood injuries, albeit I find looking at extensor tendons much more difficult than the flexor tendons because they tend to be a lot thinner. You could look at things like carpal tunnels, and if an orthopedist is wondering if the patient has a palmaris tendon for graft harvesting, you could put the probe on the patient and see if they have a palmaris tendon that they could use for a graft. Okay, now we could change gears and kind of look down the lower extremities. So I'm gonna look at the anterior hip. So on MRI, this is what an anterior hip looks like. You can see the round femoral head that's centered in the acetabulum. And if we were to put the probe on the patient along the anterior hip, the ultrasound image will look like on the right-hand side of the image. If I were to put arrows, the green arrow, the green circle denotes the anterior acetabulum or the anterior acetabular wall. The purple circle denotes the round femoral head. You can see the blue arrow pointing to the hyperechoic psoas tendon, and the yellow arrow points to the iliacus muscle that's basically just adjacent to that psoas tendon. If the patient has pathology like iliopsoas bursitis, the MRI images will look like the MRI images are on the left-hand side of the screen, and the ultrasound images are on the right-hand side of the screen. And if I were to put arrows on relevant structures, the blue arrow in this case points to the normal psoas tendon. And you can see on the ultrasound, the psoas tendon itself, to me, looks relatively normal. It has a hyperechoic, thin, fibrillar appearance. And you can see how the the psoas tendon is actually surrounded by anechoic structures on the ultrasound image, denoted by that yellow arrow. And you can see the same findings on the ultrasound, on the MRI on the left-hand side of the image. And this is a case of iliopsoas bursitis, which is often which is a U-shaped structure that kind of like, goes on the medial and the lateral side of the iliopsoas tendon. And this is exactly what it looks like under ultrasound. And the green arrow points to the femoral neurovascular structures. So if the patient has something like iliopsoas bursitis, it's something that we could certainly see under ultrasound. And if you see it under ultrasound, you could certainly offer the patient something like iliopsoas bursal injection. So just like any kind of injection within around the tendon, we're not really injecting in the iliopsoas tendon or the psoas tendon itself. We're just injecting just adjacent to it. The landmark I use is the iliopectineal eminence. And just like any other injections, I use a combination of steroids and anesthetic. And the video's not playing, but you should kind of like, see the steroid kind of surrounding that normal psoas tendon when you're injecting these cases.
Maybe clicking with the mouse.
It's okay, no biggie. So we've looked at the anterior hip. We can also look at the lateral hip. So I'm just going to put some arrows on it just to kind of make it easier. So we're going to put the probe along the patient's lateral hip, and the images that we're going to get are on the right-hand side of the image. The blue arrow points to the gluteus minimus tendon insertion into the anterior facet of the greater trochanter. The yellow arrow points to the gluteus medius tendon insertion into the lateral facet of the greater trochanter. And on top, you have this thin hyperechoic fibrillar structure, the iliotibial band, kind of like overlying those two structures on top of the greater trochanter. And you can see how I'm just trying to show like images that correlate with each other, the MRI on the left-hand side and the ultrasound on the right-hand side. So we could diagnose things like gluteus minimus tendon tears. So the normal image is on the left-hand side of the image. I've kind of labeled the anterior facet and the lateral facet of the greater trochanter, and you could see normal hyperechoic tendons inserting into the anterior and the lateral facets respectively. The blue arrow points to the gluteus minimus, and the yellow arrow points to the normal gluteus medius. And on the right-hand side of the image, if you have a patient who's comparing of, say, lateral hip pain, you could see the patient still has a normal gluteus medius tendon insertion into the lateral facet, denoted by those hyperechoic fibers. But if you kind of focus in on the anterior facet, instead of normal tendon fibers, you're now seeing fluid. So just like a lot of the cases that I've shown previously, when a patient has tears or pathology in a tendon or a ligament, those tendons either become hypoechoic and thicken, or if you have a fraying tear, the tendon is now retracted and that potential space is going to be filled with fluid, which is what's going on with the patient on the right-hand side of the image. So say you've looked at the anterior facet and the lateral facet and the minimus and the medius are intact, but patient is still complaining of pain. Well, you could use that same visit to go ahead and inject the greater trochanteric bursa. Again, my images aren't playing, but that's what we would do. So a lot of the times we would look to see if the tendon is intact. If it's not intact, then that's where our examination would end. We would say gluteus minimus tendon tear, and that's pretty much all we do. But if the tendons are intact, well, patient's pain is likely not coming from those tendons. So then we do kind of go one step further and inject something like the greater troch bursa, of course, if that's what's requested of the referring physician. So that we could say, okay, the tendons are intact, and we also gave this patient a greater troch bursal injection. If the patient's still in pain, now we've ruled out kind of two things at once. So that's something that's like, one of the benefits of ultrasound is that you could do a kind of like a diagnostic exam and also a diagnostic injection at the same time, if it's warranted. Quick thing about snapping hips. Ultrasound is, I think, a great modality looking at snapping hips. This is not really something we could see under static imaging like MRIs or CTs, because patients are only experiencing symptoms when they're moving their hips in a specific way. With the internal snapping hip, it's that iliopsoas tendon hitting against the bone. With the external snapping hip, it's the greater troch snagging against the iliotibial band or the gluteus maximus, as you can see on these graphical images. So what we can do is we could basically put the probe on the patient, have them reproduce their maneuvers, and see if those tendons snap against the bone. So ultrasound is a great examination if you're considering snapping hip as the underlying pathology in the patients. Moving further down along the lower extremity. So this is a knee x-ray on the left-hand side and an MRI on the right-hand side. I'm just gonna put the probe down in the region of the patellar tendon as an example. And you can see the purple circle denotes the patella, and the green circle denotes the tibial tuberosity or the proximal tibia. And you can see how a normal patellar tendon spans those two structures. And I think by now everybody is pretty comfortable with what a normal tendon looks like or a normal ligament looks like. And I think this ligament looks pretty normal between the patella and the tibial tubercle. So say we had like a 66-year-old female who came in with a total knee arthroplasty and they couldn't extend their knee. Well, you could certainly put your probe on the quadriceps tendon and the patellar tendon, make sure those are intact. But say that say the quadriceps and the patellar tendon were intact. So then you could put your probe on the scanning plane of the patella just to see what's going on. And if the patient's ultrasound looks like the right-hand side of the image, you could kind of ask yourself, okay, what's going on here? You could see how there's on the right-hand side of the ultrasound, you could see that hyperechoic line probably denoting the patella. On the right-hand side, again, a hyperechoic line denoting the patella, but then there's like that fluid gap in between those two structures, denoted by that purple line. Well, the patient subsequently got an x-ray, and this is what the patient's x-ray looked like. And you could see how that purple line basically denotes the gap between the patellar fracture. So ultrasound is not great for looking at fractures, but if you have an opportunity like this, it's something that that can guide your management. This patient, for some reason, didn't get an x-ray first. They basically went straight for an ultrasound because I think they had like a high suspicion of a quad tear or a patellar tendon tear. But if everything looks normal, you could certainly kind of like, use your clinical judgment to kind of tailor your examination even further. And in this case, we were able to diagnose a fracture with ultrasound, which I thought was kind of cool.
And do you have any tips when you're scanning to kind of prove that out, that following the tendon down to the tibia to make sure that you're not seeing tib?
Yeah, I think as long as you feel comfortable that you caught the whole structure, I think patellar tendon, like I was showing on this image, I think it tends to be pretty easy to find. And you just want to make sure that you're catching the patella on your superior-most image and the tibial tubercle on your inferior-most image. And I think you could be pretty confident if you could show those two sites of insertion. Oh, Baker's cyst. So, I mean, a lot of the times Baker's cyst is like, not a equivocal diagnosis, but I think my pet peeve is when people just look at this like big hypoechoic structure on the back of the knee and just say Baker's cyst. So it could be a Baker's cyst, but you really don't want to put yourself up for litigation or misdiagnosis. So the thing that you have to show when you're looking at a Baker's cyst is the neck right there. And that neck is always between the semimembranosus and the medial head of the gastrocnemius. So if you can't show me that neck, where that big cystic structure is arising from, to me, it's not a Baker's cyst. It could be like a necrotic tumor, necrotic lymph node. It could be any number of things. So if you're looking at the patient's popliteal fossa and you're thinking Baker's cyst, make sure you kind of take a look at that neck. And if you can't see that neck, patient probably requires follow-up with MRI just to see if there's anything else going on, or if it could be like a tumor or like a mass. And as long as you could confirm that diagnosis, you could certainly aspirate it and inject it with some steroids and some anesthetic to kind of provide the patient some relief. Okay, so ankle x-ray. So on the left-hand side, you have a normal x-ray and then an MRI on the right-hand side. You could put the probe on the patient. And this is one of those cases where you could see, again, a normal hyperechoic Achilles tendon inserting into the calcaneus. The normal Achilles tendon is denoted by that blue arrow, and you can see a normal calcaneus denoted by that purple circle. And you can see some posterior acoustic shadowing occurring from that calcaneal bone interface. So this was a patient who felt like they got kicked while they were playing basketball. And this is one of, I feel like, the most satisfying exams with ultrasound. right? You put the probe on the patient, you could see like a firm defect between the two Achilles tendon, and you could diagnose a complete Achilles tendon tear. This could take as short as 5 minutes and provide the patient with immediate diagnosis. This is what a graphical representation looks like. You could see that retracted tendon denoted by the blue arrow, and you can see that Achilles tendon tear denoted by the anechoic defect between the tendons denoted by that yellow arrow. I just want to talk a little bit about the lateral ankle in particular. So you have the peroneus brevis tendon that's deep to the peroneus longus tendon. And if you were to put the ultrasound probe on the patient's lateral ankle, this is what it would look like. You could see that peroneus brevis tendon is more superficial. I'm sorry, peroneus longus tendon is more superficial, and the peroneus brevis tendon is deeper. That's denoted by that yellow arrow. So say you scan the patient and this is what you see. And you can see how the tendon equitexture looks normal with both the peroneus longus tendon and the brevis tendon. It's hyperechoic and fibrillar. But this patient had an intra-sheath subluxation of the peroneus brevis tendon. You could see how that peroneus brevis tendon kind of slips above the peroneus longus tendon as they're circumducting their ankle. So this is, again, kind of like one of those pathologies that you can only see under dynamic ultrasound because you can't really see this under a static MRI. So it was like I thought it was like a cool example of the utility of ultrasound. And patient basically felt this only when they were doing that, specific maneuver. So we just had them circumduct their ankle and take images as the patients are doing those maneuvers. And then briefly, just about the medial ankle. So a lot of structures in the medial ankle, right? Things like tibialis posterior, flexor digitorum longus, the neurovascular bundle, and the flexor hallucis. If you were to put your probe along the medial ankle, you could see all the structures that I've pointed out. The yellow arrow points to the tibialis posterior tendon. The pink arrow points to the flexor digitorum, neurovascular bundle denoted by that white arrow. And you can even see that deeper flexor hallucis longus tendon. Even though some patients who are like edematous or kind of like have a big body habitus, it might be difficult to see. But say you're wondering about flexor hallucis longus tendon injection. You certainly really can't go in the yellow arrow line, right? Because you're gonna just traverse those neurovascular structures. So then what can you do? You could go from the other side of the Achilles tendon. And the only things that are along the lateral ankle that you could potentially injure are like the lateral sural nerve and the lesser saphenous vein, but you could generally kind of avoid those two structures. So if you're thinking about doing a flexor hallucis longus tendon injection, just make sure you go from the opposite side of the Achilles tendon from the lateral ankle rather than the medial ankle. You could see on the lower ultrasound image, you could see that needle kind of parked right adjacent to that flexor hallucis longus tendon. Often I feel like seeing in runners and bikers. So that was this patient. I think she was like a runner, and we just injected the patient's flexor hallucis longus tendon. You could certainly use ultrasound to guide your injections so that you're avoiding the vital structures like the neurovascular structures. You could certainly use it for things like joint injections, like subtalar joints. I feel MSK ultrasound is pretty helpful for because those are pretty difficult joints to inject otherwise. If you're wondering about Morton's neuroma, you could certainly use ultrasound to kind of make your diagnosis and even inject those neuromas. So this is just like, how we're doing it now. It's at the new hospital every Tuesdays and Thursdays.